Hello, everyone. My name is Sabrina Sholomon. I have been a liaison with MegaAid for almost 10 years now, and I am delighted to welcome Dr. Nana Sarpong. He is an orthopedic surgeon at Columbia Medical University Center and specializes in hip and knee replacement. Dr. Sarpong, thank you for joining me here today to go over osteoarthritis.
Thanks so much for having me, Sabrina and Mega. It's a pleasure to be here and look forward to a great dialogue and great conversation about topicals and treatment of osteoarthritis.
Great. So let's move on to the next slide. And osteoarthritis is a degenerative joint disease, and it can affect many tissues of the joint. It is by far the most common form of arthritis, affecting more than 32.5 million adults in the United States. It is associated with substantial disability and reduced quality of life. Historically, osteoarthritis was known as a wear and tear condition that's generally associated with aging. We now know that it is a disease of the entire joint, including bone, cartilage, ligaments, fat, and the tissue lining of the joint called synovium. Over 80% of adults older than 55 have osteoarthritis. And Dr. Sarpong, can you elaborate? From my understanding, between the two bones sits articular cartilage, and the progressive loss of the cartilage causes friction?
Yeah, that's exactly right, Sabrina. So basically, we all have, articular cartilage at the ends of our bone. So the femur, which is our thigh bone, and then the tibia, which is our shin bone. The bone that's also often forgotten is the patella, which is the kneecap. And so you have articular surface surrounding that as well. And basically what arthritis is like you just said, wear and tear, loss of cartilage thinning over time. And sometimes that could be from, activity, from overactivity, wear and tear. It can be genetic. And so sometimes, grandma had arthritis and now their child also has arthritis. It can be from inflammatory conditions like rheumatoid arthritis, psoriatic arthritis, lupus. And sometimes it could just be from trauma. And so there are different etiologies for cartilage loss.
Yes, yeah. Osteoarthritis can affect any joint, typically affecting the weight-bearing joints, such as the knees, hips, and lower back, like you had mentioned. And also factors that can contribute to the development includes age being the biggest factor, joint injury, overuse of the same joint, weak muscles that don't provide joint support, and excess weight, which adds stress and pressure on a joint. Environmental factors like someone's occupation and diet can also have an effect. I'm curious, Dr. Sarpong, do you see younger people affected too, like those who have had a torn ACL that goes untreated?
Yeah, absolutely. In ACL deficient patients, we see a pattern of anteromedial arthritis. And so those are the patients I will see sometimes who are seeing us in consultation for medial unicompartmental arthroplasties. But we see a lot more often patients who've had meniscus injuries. And as a result, when you lose that shock absorber, which is a meniscus, you get early wear of that compartment. And so I would say that's more common than the ACL deficient patient.
Mm-hmm. Okay, that's great to know. And then looking at the signs and symptoms, they typically show up in individuals over 50, but these symptoms tend to build up over time rather than show up suddenly. And typically, what kind of patient comes into your office? What do you see? How do they describe the pain?
Yeah, I think you're spot on, Sabrina. I mean, this is not something that happens overnight. This is something that usually will present as a nagging chronic pain. And so they've had it for a couple of weeks, months, sometimes years. And it's usually a dull or achy pain that is just not, improving with time. It's worse with activity, worse with weight bearing. And with arthritis, people will say, there's a folklore that, they can tell when it's going to rain because, their arthritis symptoms flare up. And so we hear a lot of those symptoms. The pain can be, localized medially, laterally. So the inside of your knee, the outside of your knee, or the front of your knee, depending on where exactly the arthritis is in the knee. I think of the knee as a 3-room home, and so the medial compartment's one room, the lateral compartment's one room, and the patellofemoral joint is another room. And in the hip, again, it manifests as groin pain. Everyone thinks the hip joint's actually in the back here on the side, but hip arthritis actually manifests as deep groin pain.
Mm-hmm.
And so oftentimes when patients are coming to present with, significant hip arthritis, they're endorsing, deep groin pain that radiates down to their knee, the inside aspect of their knee.
Okay. All right. And then does the pain come at certain times of the day for them?
Usually worse with activities. A lot of patients will endorse, again, woken up at nighttime because of pain. Arthritis pain tends to do that, but it's usually with activity as the joint is being loaded.
Mm-hmm. Yeah. I've heard of people who complain about pain in the beginning of the day, and then right after an activity, they complain of a lot of pain.
Yep. Yeah, that's a good point. With inflammatory arthritis like rheumatoid arthritis or psoriatic arthritis or lupus, people will typically endorse stiffness when they first wake up in the morning and pain, and then it sort of gradually improves with time. With primary osteoarthritis, it's usually the opposite. It worsens with activity. That's a good distinction.
Okay, thank you for that. And then regarding diagnosis, uh, you do a form of X-rays and MRI and take a medical history.
Yep. So the first thing that we do is you got to talk to the patient, figure out what exactly their story is. When did this start? How long has it been going on? What they've done for it so far? Are they taking, oral pain medicines? Have they had injections? And then the next step in treatment is the next step in their interrogation is a physical exam. And so figuring out where their location of their pain is and any maneuvers that, may or may not exacerbate the pain. And then, looking at their range of motion, whether it's the hip or the knee joint, to see if they're limited because of a mechanical issue from the bone spurs or the osteophytes being in the way. And then obviously you always have to do a good neurovascular exam to make sure they've got good pulses and your nerves work distally. And then, yes, the next step in the diagnostic testing would be X-rays. We always start with X-rays as orthopedic doctors and surgeons. We love looking at X-rays, and so that's usually an orthogonal view, so 2 or 3 views of the joint, whether it's the hip or the knee, looking to see if there's arthritis. And there's basically 4 cardinal signs of arthritis. There's joint space narrowing, number 1. There's subchondral sclerosis, which is basically when the cartilage wears out, it's the body's way of responding where bones start to get close to each other, and it basically the ends of the bone gets really hard and sclerotic. Sometimes you'll see subchondral cysts, which are basically little cysts underneath the cartilage surface. And then the last feature is bone spurs or osteophytes. And so we'll typically start there. Those are the things that will as far as our diagnostic measures go. History, physical exam, and then, obviously radiographic measures. In rare cases, when X-ray findings are subtle and you're worried about a meniscus tear, that would prompt us to get, an MRI. But, for general run-of-the-mill osteoarthritis, it's typically diagnosed with plain X-rays.
That was very comprehensive. Now on to the medication part, because there is unfortunately no cure for osteoarthritis. Medications are used to help ease pain. There are pain and anti-inflammatory medications that are available as pills, syrups, patches, gels, creams, or injectables. And each class of medication is associated with a unique balance of risks and benefits. We will talk about the different drug classes that treat osteoarthritis pain. Firstly, I'll go over analgesics. They are pain relievers, and they include oral acetaminophen, also known as Tylenol. It's available over the counter. There's also opioids, and those are available by prescription for patients experiencing chronic osteoarthritis pain. And moving on to nonsteroidal anti-inflammatory drugs, also known as NSAIDs, they're probably the most used medication to ease pain and inflammation in osteoarthritis. Ibuprofen, naproxen, and aspirin are available over the counter or by prescription together with other NSAIDs at higher strengths. So to go over the pharmacology of NSAIDs, cyclooxygenase 2 is an enzyme found in the body. It includes joint and muscles, and it contributes to pain and inflammation. Most NSAIDs block cyclooxygenase 1 and 2 isoenzymes, so that reduces pain and inflammation. It is important to note the adverse effects associated with NSAIDs, like GI bleeding, blood pressure changes, renal function, and fluid retention. And Dr. Sarpong, in your practice, how often do you probably use NSAIDs? Probably quite a lot.
Yes, I would say NSAID is an essential vitamin for an arthritis doctor. And so, yeah, a lot of my patients are sort of the first line in treatment. We would typically use a prescription strength anti-inflammatory, many of which you've described, like naproxen, celecoxib, or meloxicam.
Well, they have great outcomes. They do help with the pain and inflammation.
And to your point earlier, obviously, you're always robbing Peter to pay Paul. And so the COX-2 specific inhibitors sometimes are helpful because you don't get the GI toxicity, the GI side effects that you typically get with all the other NSAIDs.
Oh, absolutely. With the COX-1 comes the adverse effects of the GI bleeding. So to be able to differentiate which NSAID to use, COX-2 specifically, like you said, celecoxib, you can avoid some adverse effects. And moving on to counter irritants, they're topical over-the-counter ingredients such as capsaicin, menthol, camphor. They actually work very interestingly because they irritate nerve endings and the painful area feels cold or warm, and that takes away focus from the pain. So in these cases, when patients try those, they immediately feel a sensation of something really hot or cold in that area, and their focus is just taken away from pain. And patients have great results with those.
Yeah, that's been my experience actually I will say as someone who's tried both of those agents. It's a game changer for inflammatory conditions like bursitis. I've used both of those agents and it's gives great relief.
That's wonderful. I'm really glad to hear about that. And lastly, I'll just briefly mention anesthetics, lidocaine. It's available over the counter and via prescription. It works exactly how it should as an anesthetic. It helps with pain relief, and patients also get great results with that. It works lovely.
Yep, and then the two sort of additional medications that I would add, I guess one additional treatment, and then there's sort of subgroups would be injections, right? And so we always go up the ladder in the least invasive treatments. And so all of the medicines that Sabrina just highlighted here, obviously along with doing things like physical therapy, the next step in that, if that's not working, would be things like injections. And that comes in two different flavors, or a couple of different flavors for that matter. So corticosteroid injections localized into the knee to help with pain relief. And I'll oftentimes include lidocaine, a longer acting Marcaine type medicine, and then a corticosteroid, which will kick in days and will hopefully last for months. The other flavor of injections is viscosupplementation, also known as gel injections. And that basically functions to lubricate the joint, to give them more buoyance and give them more space. Obviously, there are academy guidelines on when that's effective. When you've got severe bone-on-bone arthritis, that might not necessarily be as effective. And then, now there are more experimental, which are not technically approved by insurance companies, things like PRP, platelet-rich plasma, and stem cell injections, which are technically off-label and considered experimental. But those are the different variations in the injections that are available today.
Yeah. And here at MegaAid, we make a topical compound where we mix multiple active ingredients, like the ones I had mentioned before. It's a great option for patients to avoid drug interactions, or those who have a disease such as gastric ulcers or reduced renal function and they cannot take oral NSAIDs. So one of these formulas that's up above is a diclofenac 10% with camphor 5% and menthol 5%. And it's targeting pain in two different ways. patients can apply the cream twice a day. They feel the cooling effect right away, followed by the anti-inflammatory response from the diclofenac. And using topical NSAIDs results in a local analgesic and anti-inflammatory effect by directly absorbing through the skin. Now, it's multimodal by having two different mechanism of actions in this tube, and applying it topically will have it focused directly to the area of where the pain is happening. As long as the patient's correctly counted on the correct amount to apply and how frequently to apply, compliance is also very important in these moments. And anything you'd like to add?
No, I'd say, I use this. I guess we'll get into the patient population where I think, these agents are a game changer for. I take care of very sick population, sometimes patients with end-stage renal disease who can't tolerate, oral anti-inflammatories like you were describing, because you get the renal toxicity side effects, or patients who've got, bad gastritis, they've had sleeve gastrectomies and other procedures for weight loss, and so they can't tolerate NSAIDs. Or there's another subset of patients who are on strong blood thinners, anticoagulation medicines for things like atrial fibrillation or strokes, who are on high dose anti-coagulation agents that they can't be on oral anti-inflammatories due to a bleeding risk. I think this is a perfect alternative for those patients, and my patients swear by it. And so I totally support it, and I think it really gives them sort of the local target and local relief without the systemic side effects that we typically see with the orals.
Couldn't agree more with you. I actually want to go over the difference between topical versus oral therapy, and a big difference between local and oral pharmacologic therapy is avoiding the first pass metabolism. By using topical medication, you're bypassing systemic absorption, which benefits the patient tremendously, especially for the medication that causes systemic side effect, like we mentioned earlier with oral NSAID use. Also, let's not forget the drug-drug interaction. Just like you mentioned earlier, patients combining oral NSAIDs with blood thinners like Coumadin, warfarin, it increases the risk of bleeding. And some oral NSAIDs can cause kidney failure when combined with blood pressure medications like ACE inhibitors or diuretics, which remove excess fluid. On top of which, an oral medication, you're taking one at a time for different reasons, whereas topically you can combine different classes of medications together topically, so you're having to do less, but at the same time gaining more. And the outcomes are quite great, honestly. And using this locally versus orally, you're seeing much less adverse effects, because to be able to get a systemic side effect, you'd have to apply it to more than 10% of your body surface area to have some systemic absorption, to be able to trace it in the blood. So these patients are doing really well with topical therapy.
Yeah, it's essentially, I don't want to say impossible, but near impossible to overdose this, because you got to imagine if you're putting it just on your knee is way less than 10% of your total body surface. Same thing on the hip side. And so you're really getting this local target and local relief that, I think is a real game changer.
Yeah. And I wanted to go over something, since we're already talking about this medication, I wanted to go over something that Mega8 does here called medication therapy management, what I also call MTM. And it's a service that we provide here at the pharmacy. We educate each patient on the use of topical compounds and focus on compliance and therapy. We counsel patients on the proper use and measure their pain scale before and after using the medication to track their pain. We follow up with the patient, and based off of response that they have, we work in collaboration with the provider on adjusting the formula to better suit each patient's needs. So when a prescription comes in from such as yourself, we educate the patient why they're using this, for example, whether it be osteoarthritis in this case. counsel them on the condition as well as how to apply it, how many grams to apply it, how many times a day. We like to take their pain scale before they start using it so that when we call for a follow-up, we know how they're doing after. And if the patient reports back that they're doing great on this therapy, that we can continue treatment, that's wonderful. However, if they say that they'd like to try something stronger, then myself or one of the clinical pharmacists can reach out to you and ask if you're open to trying something different for this patient. And we work collaboratively together with the provider to make sure that the goal is to make sure the patient is getting positive treatment from this therapy.
Yeah, absolutely. And, I think that's been my experience with you, Sabrina, is a sort of dialogue and, constant feedback on how patients are doing. You're constantly checking in on the patients. And the patients obviously, getting good relief and are receiving it well on your end because countless times you have asked me if it's been okay for, patients requesting refills. And the answer is always unanimously yes. If it's giving them relief, why stop it?
I'm really happy your patients are doing well. And actually, another service we do that I'm sure you also provide to your patient when you do the physical exam is and medical history exam is the drug utilization review. When we speak to the patient later on in a follow-up, we want to know all the medications the patient takes, regardless of which provider, to be able to identify the potential interaction or even potential duplicate therapy for these patients. I've spoken to patients and only to find out that they're on certain medications where I can offer them something topical that might help them with less side effects versus the oral medication. And when I call the doctor and I find out that, and I offer that to them, they're incredibly satisfied to know that this exists. Sometimes, they invite me to their office then to meet with them because they didn't know this exists until I come in and educate them on this. And going over a patient's medical history can be extensive because they have so many different medications they've received from different specialists they've been to, whether they've checked into even a hospital and then they get discharged with a different medication. For someone to sit down and go over everything with them and why it's being used, sometimes over the phone they tell me it's a round yellow pill and we have to go over and read spell out what's on the bottle so they know, and they really appreciate the attention so they know exactly what they're taking, why they're taking it, and how often to take it.
Yeah, I think this is an incredibly added value and added service, and I think it's definitely appreciated from a provider standpoint because, as you know, our clinics and our schedules are full with, patients, running every 10 to 15 minutes, and having some help, from that end, especially when you're treating a sicker population, to be able to go over the medicines and the side effects and the medicine interactions is key, and it's very helpful. So that's appreciated as well.
Oh, that's great. And I love to be able to come back to you and verify if any questions regarding the patient and just to make sure they're doing well. I'm glad that we can work collaboratively together on benefiting the patient.
It's a team sport as long as the patient's doing well.
Yes, that's most important. And with that, I'd like to see if there's any questions from anyone and if there's anything we can do. Oh, let's see. I have one of my doctors. What natural supplements do you recommend for your patients with arthritis?
Yes. So for Samuel, to answer your question, that's a good question. So arthritis is an inflammatory condition. And obviously, as an anti-inflammatory, that's not necessarily a medication. They're natural anti-inflammatories. So have heard a lot of patients who come in to see me who say, I've done garlic, and that's a great anti-inflammatory. Things like turmeric, cherry tart, those are all great natural supplements that you can try. People will take glucosamine tablets, which is basically a gel that will help lubricate the joint, especially if you've lost lubrication with the arthritis process. The jury's still out on that, but for some patients, it really gives them some relief. I don't see any harm in doing that. So you can try that as well.
Thank you, Dr. Adegboyega, for your question. And also, it looks like we have someone that might want to get into contact with your office.
Yes, absolutely.
And
You can totally reach out to our office. You can call 212-305-1722. Again, 212-305-1722. Happy to see you and help you,
Dr.
Christine.
Sarpong is a very reputable orthopedic surgeon with quite a wait list for how great of a doctor he is.
Thank you.
And if we don't have any more questions, I guess thank you so much for listening. And thank you, Dr. Sarpong, for joining.
Thank you so much, Sabrina, and thank you for Mega Aid for this incredible dialogue. And I learned a lot from you, and happy to be here. Thank you.
Thank you as well. Thank you for everybody for listening. Oh, orthobiologics. Hold on.
Yep. So orthobiologics is not really my area of expertise. We have a subsect of doctors within our division who specialize in things like PRP and stem cells. As a surgeon, I will tend to refer those patients to that division. But again, because a lot of this stuff is considered experimental by insurance companies, this is typically an out-of-pocket expense. I don't want to I want to make sure that this is not a cost prohibitive thing for the patient.
Very understandable. Thank you everyone for joining. And if you have any questions, leave some comments. I'd love to see them later on in the future and answer. Thank you.